So we'll skip the introductory comments since we already introduced ourselves. But what we're talking about here is a demineralized bone fiber implant that's used at the tendon to bone interface. So it doesn't go over the top of the tendon. It goes between the tendon and the bone. And in fact, it's inset within the bone as an augmentation for rotator cuff surgery. We've already talked about the fact that this is a common problem and actually increasing in frequency, about 500,000 cases per year in the United States. I'm sure it's similar in terms of the case volume relative to the population in Australia. And the problem that we deal with is this concept of failure. And failure can occur from mechanical factors, but in large part in 2025, it's occurring because of a biologic factor. And these tears can be anywhere from 10% or re-tears anywhere from 10% in the smaller tear environment. And in some of the larger tears where we deal with greater than 50%. But we also see what we call tendon failure in situ. And what that means is if you think back to your anatomy and histology and pathoanatomy courses that we all took in medical school, the enthesis is really designed or defined as this organized transition from tendon to bone. And that's designed to help distribute load across the footprint between where the tendon and the bone attaches. And it works in multiple planes. So it's not just if you're abducting or flexing, but when you're rotating, all of the different planes that you think about within shoulder motion. If we take a closer look at what does this biology look like, take a look at this slide, and this is basically a path slide looking at the histology of the tendon to bone interface. And what you see is it's a very organized transition zone. We go from tendon to uncalcified cartilage to cartilage, which is calcified, and then finally to bone. And this is all designed around strength of the bone tendon interface and load transmission and distribution in an organized fashion that can support all of the different loads that come across the tendon in terms of shear, pulling, and twisting stresses. Now, unfortunately, as Ashish kindly mentioned, is we don't get that when we do rotator cuff surgery. What we get is this is randomized mix of scar tissue within the interface. And if we look at this more broadly, what we see in many cases is that you have bone, you have scar tissue, and then you get to tendon. So it's almost failure in situ where you've got a bridge of scar tissue between normal tendon and bone. And that just doesn't function well. It doesn't distribute load appropriately, and it doesn't hold up over the stresses over time. And the idea is how do we more normalize that to improve outcomes for the patient, both in terms of clinical outcomes, in terms of the percent of tendon healing, but also potentially in terms of accelerating or improving on the outcomes following rotator cuff surgery so patients can feel more normal and function more normal, which is at the end of the day what they want. We know that this fibrovascular scar is mechanically weaker and it is prone to failure over time. So it's not uncommon that you see these patients that you operate on and 10 or 15 years later, they come back and they have re-tears or expansion of tears and are progressing to rotator cuff arthropathy and need a secondary innovation. So as we already talked about, and I won't belabor the point, much of the work that's been done to date is the idea of how do we benefit the collagen? How do we make the tendon more robust? And that usually informs or involves some form of over-the-top fixation with either collagen, allograft, or xenograft, or in some cases, even potentially artificial products that go over the top and try to help collagen integration. But that doesn't solve the problem that we've been talking about, which is how do you get that normal interface between the tendon and the bone, which is really where the interest in this product has evolved. The idea is that if you can do enthesis reconstruction, you can improve biology, you can improve biomechanics, and there is some preclinical data that really would support the use of DBM, which is demineralized bone matrix, in this fashion. The hard part is how do you get DBM into a usable format? DBM is really just nothing more than allograft bone. The nice thing about it is it contains both osteoinductive and osteoconductive properties. It does contain some of the BMPs that we would think about as helping to form biologic healing. And it heals by a process of end chondral ossification. So you create a defect, you fill the defect with this allograft bone, you get end chondral ossification, and the body is smart. It knows that if end chondral ossification is occurring at a bone tendon interface, it doesn't just create normal bone, it actually creates the bone tendon interface. So by creating a bone defect and asking the body to fill the bone defect at the site of a tendon to bone insertion, you're actually stimulating bone tendon healing rather than just laying the tendon over the top, in which case you're not really inciting that response and you get scar tissue formation. And this has been supported in multiple preclinical data that have demonstrated that when you use a bone graft at the site of a bone tendon interface, you get a more normal appearance of a four-layer transitional zone, similar to the enthesis that we just talked about. Now, traditional DBM is hard to manage because it comes in almost like a powder format. So how do you deliver that into an environment and make it usable for a surgeon other than potentially just packing it into a cyst cavity or something of that nature? And that's really where this demineralized bone fiber has been valuable. And the key here is in the harvest technique. So what you do is you take long bones and you actually use like a cheese grater type effect to take long fibrils of collagen and bone in the direction of the collagen environment. And so what that does is it allows you to get a 3D architecture. And depending on how you prepare those fibrils, you can get them to be stiffer, more malleable, less malleable, and you can make them into shapes. And so the way that this product evolved was in the spine, where they actually created these dowels that would go into a pre-prepared pedicle hole. You would then put a screw down the hole, and that would do two things. It would improve the screw fixation, almost the same way that you put a dowel into your drywall and then put a screw in. Your fixation gets better, but it also gives you some value of bone at the bone tendon interface. And so we thought about, now that we can 3D manufacture these types of implants, how can we use this in the setting of rotator cuff repair? The nice thing about it is we don't have to go through a big authorization process. This is simply allograft bone. So we're all comfortable with using it. We know that it's safe and effective. And we also know that we can design it in a way such that it meets the needs for the surgeons in terms of how do we implant it and get it to stay there without minimal change to our surgical technique, minimal time added to the surgery itself. As a result, we were able to develop a widespread product portfolio that's available for use with whether you use hard body anchors or all suture anchors, whether you want to integrate the product into your anchor or use it separate from the anchor, whether you've got a small amount of exposed tuberosity or a larger tear with a larger amount of exposed tuberosity. And this has now been available since 2023 in July with a gradual launch that's happened over time. And Ashish is going to share with you some of the preliminary data we have regarding outcomes for patients, as well as the MRI appearance of what these tears look like. But just to give you a sense of the widespread use, about 750 cases per day to about 1,600 implants and approaching 1 to 2 year follow-up for many of these patients. So a robust clinical data. I'll just share with you briefly the technique. This is a patient who has about a 2 centimeter tear. We've already put in our anchors. We've already passed our sutures for our medial row. Now what we're going to do is create the bone defect for the DBM or DBF implant. And we do that just with a standard punch as you would do for a normal arthroscopic procedure for inserting an anchor. But then we use a secondary cutting guide to basically create a recessed indentation within the bone that will then be used to accept the implant. In this case, we're using let me go back. We're using a taco implant. So one of the nice things here is you can see by actually penetrating the subchondral bone, we get marrow egress, so we access some of the marrow elements. The implant is loaded onto an insertion handle. It's then deployed into the pre-prepared defect. It sits flush with the surrounding bone. This is literally the amount of time that it takes for the implant to go in. And you can see that we continue to access the marrow, but we have now also implanted the allograft within the bone to stimulate that process of enchondral ossification. And that's it. Now you go back and you simply finish your rotator cuff repair. So you've already got your sutures in place. You then dock them into your lateral row. If you're doing a lateral row repair, for those surgeons that like to do a single row repair, they can integrate the anchor into the DBM implant to provide the same amount of coverage, and the case is finished. And we're now thinking about how do we load the implant, potentially with things like bone marrow aspirate concentrate or PRP for further biologic activity. This is what it looks like when it's all done, your standard bone tendon repair. But again, the implant sits in the interface between the tendon and bone, which is why we say that it flips the script in terms of conventional thinking from a rotator cuff procedure. And here's just an example of how, as tendon tears get bigger, the implants can be fashioned in a way that they can fit multiple different configurations or tears or size of tears that you need. So what is the advantages? It's allograft bone, very safe. Obviously, everybody's comfortable with allograft. We use it all the time for different applications. There's no concern about inflammatory reactions. It integrates very readily into bone. It's off the shelf. It can be stored. It's not something that you need to pre-order, and it's cost effective. So I think really what we need to think about is we've really been focusing on collagen deficiency, but what about tendon bone deficiency, and how do we facilitate normal enthesis reconstruction, and how do we do that with a simple and reproducible surgical technique? And this has been kind of the thought process that went into designing the implant, the instrumentation for the implant, and finally the techniques that surround the implant instrumentation. So hopefully that's helpful in introducing the topic a little further.